Okay, brilliant. Hopefully you can all hear me. Welcome to another Bite Medicine webinar. The first with our new kind of format. As you can see, we've changed some of our designs, which our design team have managed to do. So hopefully you like it. We'd love some feedback on these as well at the end. But my name's Azim. I'm one of the co-founders of BiteMedicine. And this is Dr. James McVeigh, aka Jamie. Jamie, we're absolutely thrilled to have you with us today. Thank you so much for helping us out. And obviously, you're a very valued member of the BiteMedicine editorial body as well. So great to have you here today.
Perfect. Thank you very much, Azim. And yeah, thanks for having me on board. So just a little bit of background, guys. I'm Jamie. I am currently an F2, working at Guy's Hospital in London. I have a particular interest in surgery, and today I'm going to be talking to you. The first half is going to be about the A to E approach, and particularly because I've got an interest in acute medicine and the acute side of pathology, and in this series, the first half, we will go through A to E more briefly in future sessions, but I want there to be a theme for every session. So today that's going to be shortness of breath, and it's going to be very much case-based. So I will be throwing some cases out there, and I've deliberately not put a lot of information on the screens for the cases because I want you guys to think about how you would approach the scenarios yourself, and then I'll subsequently talk you through. At any point, please pop any questions on the chat. I'll try to keep an eye out on them on the chat, and if I ask any questions, again, just give any answers that you have. There's no such thing as a stupid question, and there's no such thing as a stupid answer. Okay, so do not be afraid to pop anything on that. Okay, so to dive straight in, this session will probably be 30-40 minutes. Okay, so I won't keep you for too long. It's intended to be short and sharp so that I have your full attention for the duration. And as I said, it's going to be looking at the A to E approach. So I'll start by talking about why this is so important in a clinical setting. I'll then talk you through the A to E, or how I do it. There's different ways people prioritize different things, but I'll talk you through my methods, but they're all very similar. And then, as I said, we'll talk through some cases focusing on shortness of breath as a symptom. So the A to E approach, why is it important? Well, it's a systematic approach, which is vital in an acute setting to ensure that stuff isn't missed. Okay, so to ensure that you have a very broad range of things that you're analysing. It's used particularly for unwell patients in hospitals, but it can be used in any clinical scenario. So there's nurses on my wards at the moment that when they're writing their notes up at the end of the day, they will just do A, B, C, D, E as their clinical summary because it's such a useful tool. It is used by all clinicians. Okay, so I've seen med students all the way up to very experienced consultants using the A to E approach, and it is very useful for that reason. Also in trauma calls, so in patients that have come in and they've had really major trauma, particularly at tertiary centres, the approach is still A to E. Okay, so if you're ever stuck, this is what you need to use. Okay, and the last reason it is so useful is because it can be stressful, particularly in F1, if it's sort of the middle of the night or late in the evening and you get bleeped to go and review someone who is sick, who is unwell. Having that in the back of your head thinking A, B, C, D, E means that you have a systematic approach that you can use to help you through. All right. There's certain principles that I'll be talking about throughout. The first is to be systematic. Okay, be vigilant with your A to E. Okay, The next thing is to escalate early. If you are not comfortable, or if you think something is wrong, or you are out of your comfort zone, escalate. Okay, there's always people, particularly as an F1, you'll have an SHO, you'll have a registrar, you'll have a consultant. Even in the middle of the night, someone will be there to answer the phone. Okay. And the last thing is it's really important to focus on communication, particularly in an acute setting, be it an A&E with, you know, lots and lots of people around to ensure who's in charge, who's running the scenario, or even on the wards, if it's just you and maybe one or two nurses. It's really important to communicate so that you can be as effective as possible, and to ensure that the patient gets the most timely and the most important treatment that they need. So to start, airway. Okay, so A obviously stands for airway. Now with each one, I sort of break it down into a look, examine, treatments type thing. So just so that you can remember. So for airway, you're looking and you're hearing and you're thinking, what am I really worried about? Okay, so the vast majority of patients that you go and see will have a completely normal patent airway. Okay, but there are scenarios where they don't. Okay, and that is very worrying. All right, so with an airway, things that make us particularly concerned tend to be noises that we hear. Okay, so if you go and see someone and they're snoring away, or it sounds obstructed, or they've got something called stridor, which is sort of a very loud effort of air trying to get through the trachea, and is pretty obvious, then you get worried. The most concerning sound for airway actually is silence. Okay, if you hear silence, you need to think, has this person arrested? Do I need to go down the cardiac arrest resuscitation protocol? Okay, I won't talk you through that today. I'll probably mention it in another session later on. Okay, and then you think, well, if the airway's patent, great, I can move on to B. If it's not patent, there's two things I need to think about. The first is, how can I make it patent? Okay, and there's a few simple ways of doing that. And the first is with just some very simple techniques. Okay, so the first one is a head tilt chin lift. Okay, so you tilt the head right back and you lift the chin up right to the ceiling. Okay, and pull it back so that you're opening the airway, and you're sort of trying to straighten it out so that there is a straight line going from the chest all the way out. Okay, it's particularly useful in obese people, because the subcutaneous fat around the trachea can often block it off, and so a head tilt chin lift is very useful for that. Another incredibly useful maneuver is what's called a jaw thrust, and that is it's typically more used in more unwell patients. Okay, so if anyone that's got a problem with the airway, they are unwell, but the jaw thrust is more useful, but it's a lot more painful. So it's typically only used for patients who have a lower GCS. Okay, if someone can tolerate a jaw thrust, then you need to be concerned about them. Okay, and that's just done by, you get your fingers right in under the angle of the mandible. Okay, and you just pull up towards the ceiling, and you should feel the jaw retract away from the face. Okay, as a med student, what I'd really recommend is any anesthetic placements you get, ask the anaesthetist if you can help with the airway. Okay, so they'll let you help with the tube, they'll let you do the bag valving, and they'll really teach you how to do these maneuvers properly in real life. Okay, because it's all well and good me telling you how to do it, or you doing it on a dummy in simulation, but if you actually do it on a real patient who might have a large BMI, it is actually quite a difficult technique. Okay, and it's well worth practicing. All right, and then you've got airway adjuncts. Okay, and these are tools that you can use to help keep the airway open. So you've got Goodell's, otherwise known as oropharyngeals, and they're sort of the size of a finger, about this long, and you just pop them in the mouth, rotate them around, and that just helps keep to keep the airway patent. Sorry, I don't have pictures for these. Next time I'll do more pictures. Another adjunct is a nasopharyngeal airway. Okay, and it's very similar. It's like an NG tube but thicker. Okay, and it's only about that long, and it goes straight back, and that helps to keep the airway patent as well. One point worth mentioning, which always seems to come up in med school exams, is a contraindication for a nasopharyngeal airway is a basal skull fracture. So in a trauma patient with head trauma, you just need to be a bit careful. Okay. And then the last thing you're thinking about is, does this person need either an eye gel, which is a tube that goes right down into the larynx, or do they need an endotracheal tube? Okay. And with any patient where you are worried about the airway, okay, so if you're not thinking this airway is patent, you need to get straight on the phone to the anaesthetist. Okay. So do the airway maneuvers, think about adjuncts, and get on the phone to the anaesthetist, because they need to be there soon. Because if a patient has a compromised airway, they are very, very acutely unwell, and they could deteriorate very quickly because they're not getting any oxygen. All right. So, but as I said, it is rare that you don't see a patent airway, but it is the most important one, and that's why it's A. Okay. Any questions about the airway? Feel free to put them in the chat. I'll move on to B, but I'll keep an eye out. So B is breathing. So first thing, you look at the patient, okay? How do they look? If you have been bleeped by the nurse and someone's short of breath, the first thing you should do is say, what are their observations, okay? Oh, here we go. A couple of questions from the chat. Yes, so an eye gel is an oropharyngeal mask is just a Guedel, okay? It's only that big. An eye gel is a proper piece of kit that goes right down into the larynx, okay, and is very good because it blocks off the esophagus. It's not 100% effective, but some anesthetists will use it in short procedures, for example, where to keep an airway open, whereas you couldn't just use a Guedel, sorry. Contraindications, yes. So for a nasopharyngeal tube to keep the airway, if you're worried about the mouth for whatever reason, a contraindication is a basal skull fracture, okay, which is often seen in trauma. Not often seen, sorry, but you need to be careful about for any head trauma, okay? And signs of that are battle signs, so that's bruising around the eyes and behind the ears, as well as CSF, so clear fluid leaking from the nose, all right? So I hope that cleared that up for you both. So breathing, look at the patient, how do they look? Hopefully you've got some observations on them already. If not, try and get them as quickly as possible, okay? So you're looking at their saturations, and you're looking at their respiratory rate first. So that's from their observations. And then in terms of the patient themselves, you're looking at their work of breathing, okay? So how do they look? Do they look tired? Is their rest rate, does it seem particularly high? Are they taking very shallow breaths, okay? Cyanosis, so are they a bit blue in the fingers? And even worse, are they a bit blue around the lips or on the tongue, okay? That's central cyanosis around the mouth is a sign of severe hypoxia, okay? So you need to be very careful there. And then use of accessory muscles, okay? So tracheal tug is one, and then all muscles that shouldn't be involved in respiration, so that aren't your sort of intercostals, your diaphragm. So if they're using their pectoral muscles, their trapezius, to really try and get more air in, okay, that's a very concerning sign as well, okay? Then examining them, you need to think auscultation, okay? That's probably the most obvious one, and it's the one you're going to get the most information from. So bilaterally, often it's only possible to do it anteriorly, but posteriorly is much better, because that's where the big surface of the lungs is, okay? So auscultate the chest, you're thinking about, is there bilateral air entry? Okay. If not, you're very worried that there might be a pneumothorax or a hemothorax on one side. Okay. The other thing is, are there creps at the bases? Thinking about pulmonary edema. Are there creps just on one side? Maybe in the mid zones at the bases, could be at the apex. Okay, that's more likely to suggest a consolidation. Okay. You can percuss as well. So percussing from the top all the way down. Dull percussion indicates that there is fluid in the pleura, so a hemothorax, or it could be a pleural effusion. Okay. If it's hyper resonant, so loud, high pitch, that is more likely, that very much suggests a pneumothorax, and that would go hand in hand with the absence of breath sounds. Okay. And again, you need to be, that's something to cause concern. Thinking about expansion as well, that just helps to see if the lungs are expanding bilaterally. So you place your fingers either side of the chest, put your thumbs together at the same level, and you should see that the chest expands up and out bilaterally. If it doesn't, then it's likely that there is a pathology in one of the lungs that needs to be investigated. And finally, just position of the trachea. Okay, so if you feel from the Adam's apple, the cricoid cartilage, all the way down, you should feel quite deep. It's a bit uncomfortable. You should feel the trachea. Okay, and it should be nice and central. If it's deviated to one side, that suggests that there's either a lobar collapse on the side that it is deviated towards, or a tension pneumothorax on the other side. Okay. Investigations then. So depending on how urgent this is, if you haven't really found much, you can move on to C. If you're worried, stay with B. Okay. You need to do treatments quickly. Okay, well, sorry, I'll talk about investigations in a minute, but you need to do treatments. The first is oxygen. All right. So if their saturations are less than 94, they need oxygen. Okay, as a general rule in the acute setting. You will have your CO2 retainers, who are typically quite late stage COPD patients, whose main drive for breathing, for respiration, is hypoxia. So if you give them a whopping great dose of oxygen, their respiratory drive goes down and they retain CO2. In the acute setting, do not worry about this. Okay, that is something to worry about after your A to E. All right. If someone is hypoxic, they need oxygen, because hypoxia will kill them first. All right. If they're severely hypoxic, you can give it through a non-rebreathe mask. You can give 15 liters. Otherwise, you can wean it down with a Hudson mask, so just a simple face mask. And if they're sort of above 90%, then you can just put some nasal specs on them and give them 2 to 4 liters. Okay. And if they're really hypoxic, you need to think about non-invasive ventilation. All right. And that will involve you contacting the medical registrar or the anaesthetist to organize that. Okay. But we can talk a bit more about that with the cases. Investigations: if someone is hypoxic, they need a chest x-ray to look for pathology. Could be a pneumothorax, could be a effusion, could be an infection. You don't know. All right. They also need an ABG. So you want to see, because SATs are good, but they're not the gold standard. So you need to do an arterial gas to see if how hypoxic they are. Okay, to look at the oxygen level and also their CO2 level, and that will give you a suggestion as to whether they're retaining, and you can think about how much oxygen they actually need. Okay. Any questions with breathing? Put them in the chat. We'll move on to C. So circulation, this is probably the one that you'll find most things are, you'll find the most problems, okay? Because typically circulation is what is deteriorated first in an acute setting, unless it is a lung pathology. So as before, we are looking, we are examining, we're doing investigations, and we're going to treat them. Okay, so we're looking, the obs for circulation that are important are heart rate and blood pressure. Okay, so are they tachycardic, and is their blood pressure low? Those are the two things that I'm worried about. And that is one of the things I will ask the nurse on the phone. So if they're tachycardic or they're hypotensive or both, then we're thinking about shock. Okay, and there's lots of causes of shock. And we need to think about why are they in shock. Okay, then looking at them, what color are they? Are they really pale? Do they look clammy? Okay, what is their complexion? Look at their mucous membranes. Have a look at their lips and their tongue. Is it particularly dry? If so, it's likely that they're hypovolemic and they're going to need some fluids. And this would be why hypovolemia would be the cause for their low blood pressure or increased heart rate. The examination for circulation. Have a good feel of their pulse. Is it very weak? Are they tachycardic? Have a feel peripherally and centrally as well, to if you cannot feel the peripheral pulse. If you're struggling to feel the peripheral pulse, that's quite worrying. That seems that they're very shut down. Have a listen to their heart as well. Are there any murmurs that you can hear? Are the heart sounds quite faint? Think about their fluid status. So as before, look at their mucous membranes. Their cap refill time is particularly useful for fluid status, okay? So just pinching the end of the finger for 5 seconds, and then you release it and see how long it takes for the capillaries to refill, okay? If a cap refill time is greater than 2 seconds, then you know, it's likely that they're underfilled and they're going to need some fluids. So there's two things you can do now if you're worried that they're in shock, depending on how bad it is. So if you've got a patient who's got a heart rate of 150 and their blood pressure is 60, 70 systolic, you need to escalate, okay? Because it's likely that they are very unwell and they're going to need some quite invasive treatment quite soon, okay? In the meantime, you need to do two things. You need to ask the nurses to do an ECG, because that'll give you a better idea, particularly if they're tachycardic. You want to know what the rhythm is. Is it irregular? So thinking about, it could just be a sinus tachycardia, but are they in some sort of cardiogenic problem, such as fast AF or SVT? And then in terms of treatments, while you're getting help, you can think about putting 2 cannulas in. Well, depending on how unwell they are, you can pop a cannula in if their blood pressure is sort of 110 systolic and they're not tachycardic, and give them some slow fluids. But if they're in shock, they need 2 large bore cannulas, so either green or grey cannulas, ideally in the ACF, as proximal as possible, just because you might need to give them some complex medications which you don't like to give through the hands. Take some bloods while you're there. That's always useful. Just take them straight from the cannula and send them off. So that's just your routine blood, so full blood count, UNEs, your LFTs as well. Depending on whether you're in a surgical environment or not, they might need a clotting and a group and save as well. And then you're going to give them fluid. So if they're in shock, give them a bolus of fluid, okay? And this is one of the most effective and useful treatments that you will use throughout your whole career, okay? So someone who is tachycardic and their blood pressure's dropped, you can give them, depending on how old and frail they are, between 250 and 500 mils of saline. Just give them like that, and see how their blood pressure responds, okay? Most will respond, and depending on the response, you can think about giving more maintenance therapy. But if they don't respond, you can try again. And at that point, you're thinking, I need to escalate this, because if they're not responsive to fluids and they're particularly unwell, they might need inotropic support. So you'll need an anaesthetist. They'll probably need a central line. So it gets quite complicated then, all right? And the last thing to just be aware, just have in the back of your mind is heart failure patients. So patients with severe heart failure and low ejection fraction. So their hearts are like floppy plastic bags. They're not beating properly and they get loads of fluid buildup. If you give them lots of fluids, it's not going to help their heart, okay? And it might make the situation worse. And it's really, really difficult in these patients to weigh up what how much fluid they need and how much you need to diurese them with something like furosemide, okay? And often what you need to do is actually you diurese them, but you also give them some sort of inotropic support as well, just to make sure that their blood pressure is maintained, okay? The last thing I forgot to put on this slide is urine output. That's a really useful measure as well. If you can see someone's urine output has dropped off over the last 12 hours or so, then you know that they're hypovolemic and you know that they need some fluid, okay? And if they're losing blood from somewhere, you replace blood with blood, okay? In shock. If blood is going and they are unstable, you need to call major hemorrhage protocol. Every hospital has it. It's 222, and they'll get you some O negative blood there very quickly. And while you're waiting for that, do not hesitate to give them some fluid boluses beforehand. Okay, so that's circulation. How are we doing for time? Disability. So this is a little bit less important than the first three. ABC are really the most important thing. But again, you need to document these, and they give you very useful guides. So the first is their GCS or their AVPU. I'm sure you all are aware of the Glasgow Coma Scale, but I've just put it up there in case you're interested in it. Someone with a GCS of 8 or less, it's worth knowing they will likely need to be intubated and need airway support. Check their glucose, because it's always a reason for why patients have vasovagals, why they might feel dizzy. You might get called to see them for that sort of reason. So it's always worth checking. Check their pupils to ensure they haven't had a massive intracranial hemorrhage, which has dropped their GCS, and then temperature as well, which is particularly important for thinking about if they've got an infection on board, which we'll talk about in one of the cases. And then lastly, exposure. So you just to sort of complete the whole systematic approach. If they are a surgical patient, have a look at their abdomen, have a feel. Does it feel soft? Does it feel peritonitic? Do a PR if you think it's indicated. Have a good look at the skin. Are there any wounds that are present that might look infected? Could be a cause of sepsis. Are there any rashes? Rashes, the main one that you need to be worried about is a meningococcal rash, which is a non-blanching rash, often on the torso, but can be on the legs and back as well. And that's a sign of meningococcal septicemia, which can be fatal in a matter of hours. And then lines, which is something I think people always forget. Have they had a cannula in for 2 weeks and the cannula site is now very erythematous and it looks like they've got a cellulitis, which is making them septic? Have they got central lines in? Have they got an arterial line in? All stuff to just have in the back of your mind. And then if it's indicated, think about their arms and their legs. Have they got a clot somewhere? Is there really bad arterial disease? You maybe consider doing a quick neurological exam. So that's the ATE run through. I will run through it again in future talks, but it won't be in this much detail. Okay, it'll just be a sort of a reminder. So after the A to E, what do we do? Okay, you've got your beautiful A to E, you've finished it off, and you think, fantastic, the patient's kind of stable, I've got help on my way. What do I do now? The first thing to always do is reassess, go back, A, B, C, D, E, what has changed? Are they improving? Are they deteriorating? Okay. And the other thing to say about that is if there is ever a change in their state, be it their GCS, be it they become more hypoxic, be it their blood pressure drops, start again, A, B, C, D, E, okay? Because if there is a change, it could be that something has happened in the interim, and the things that will kill a person quickest go in the order A, B, C, D, E, okay? Then you've got a bit of time to, well, you might not have time, but it's always important to look through their history, what's happened to them, try and get a bit of background, look at their drug charts. Are there any causative drugs for what you found? Their bloods, recent bloods, and obviously hopefully you've sent some more bloods off, and any imaging that they've had done. Think about their escalation status. Are they really frail, 95 years old? They're not for ITU, they're not for resuscitation. And once you've got all this, it's really useful to have when you're handing over to a registrar, or to your senior. It could be your SHO, your registrar, could be the anaesthetist, okay? And it all depends on how unwell the patient is. If they're really unwell and you need to hand over very quickly, and you need them there very quickly, that is fine. Okay, you can just have got as far as A, B, all right, and just say, this is all I know. I've found this patient like this. I'm very worried about them. Okay, that is completely fine. You've escalated effectively, and that is all that can be asked. All right, and then have a think about what other investigations you want to do. Is there any more imaging you need? What bloods you want? All that sort of thing. So without further ado, has anyone got any questions about that? Just pop them in the chat if you do. It's a very brief overview of the A to E, but hopefully it's helpful and has got you in the right mindset. So I've got 3 cases to discuss, okay? And I've deliberately left them quite vague because I want you to think about it. So we have got a 20-year-old man who has been hit by a car at 30 miles an hour, and he walks into the emergency department. He says he's got severe pain in the right side of his chest, and he's feeling short of breath. Okay. In this scenario, as with most scenarios in the hospital, A-to-E approach is the best way to go. Okay. So with this history alone, anyone want to pop into the chat any pathologies that they are particularly worried about for this gentleman? And then we'll run through. Yeah, exactly. So that is absolutely at the forefront of my mind. Yeah, pneumothorax. Okay. Any others? Ruptured lung, yes. Yeah, it could be a collapsed lung, but likely would be secondary to pneumothorax. Anything else in trauma? What might affect the lungs? Yes, flail chest, fantastic. Cardiac tamponade, very good. Hemothorax, yeah, fantastic. So I was thinking pneumothorax, hemothorax, and then depending on where the chest pain is, you're completely right in suggesting cardiac tamponade and flail chest as well. So these are all things to have in the back of your mind, and these are all, I'm really glad you've put these all in, because these are the things that can, well, essentially can kill you very quickly. Okay. Fat embolism, I like the suggestion, and it's always in the textbooks. I've never seen a fat embolism, and typically it would be you're right in thinking someone could have a PE, a post-traumatic PE from a fat embolism, and that is certainly a good suggestion. Okay, and we don't have enough about the history to say that that is that might not be the case. So I'll just run through it. So you see him, his airway, he's talking to you, his airway is patent. Okay, there's no strange noises. You have a feel of his trachea, and it is central. Okay, which is so you're not worried about that. You're happy with A. You move on to B. He's then got SATs of 82%. Okay, and sorry, let me get this out of the way. Respiratory rate at 25. And he's got an increased work of breathing. Okay, he seems quite tachypneic, and he doesn't seem well. You have a look, you have a good auscultation of his chest, and on the right side, there's no breath sounds. On the left side, the breath sounds are present. Okay, and he is hyper resonant percussion on the right hand side, but normal percussion on the left hand side. So as I'm sure you're all thinking, our main differential now, we focus it down to, is probably a pneumothorax. So things we need to think about now. He's got low SATs, he needs oxygen, 15-litre non-rebreathe mask, straight on him, no questions asked, try and get those SATs back up. Put him straight on a cardiac monitor to monitor his SATs and see how he goes. If you're happy with the SATs, then you can move on to C. In this scenario, I think already, if you're an F1, and it is an unlikely scenario because you probably won't be doing an F1 placement, A&E placement in F1, but as an F1 newly qualified, this is where I'd be getting help immediately at this stage. Okay. How is the difference between pneumothorax and hemothorax when examining the patient? Very good question. So pneumothorax is where the pleura, the pleural cavity, so between the visceral pleura and the parietal pleura, is filled with air. Okay. On a hemothorax, it is filled with blood. Okay, so fluid. So both scenarios, you will have reduced auscultation. Okay. Reduced breath sounds on auscultation. Okay, so you won't hear breathing, or you might do, but it'll be very faint compared to the other side. The main difference, okay, is on percussion. All right, so if you percuss the lung at the back or at the front, it will be hyper resonant for a pneumothorax. So it will be very loud, high pitched, kind of like percussing, maybe percussing like a distended stomach that's full of air. Okay. Whereas a hemothorax will be very dull because you're just percussing liquid. All right, there's no air in there, so there's nothing to resonate the noise. So I hope that's answered that question. So let's say we've asked for help, but there's no help available, or they're on their way. Okay, we've got oxygen on. We'll get a colleague to get a blood gas for us, an ABG, and we've requested a portable chest X-ray to come because we're worried about a pneumothorax. If this person was acutely unwell and you were seriously worried about them, you might need to put a chest drain in there and then. But as an F1, it's better to just get help quickly. So move on to circulation. You do his obs and you find out that this guy's got a blood pressure of 88, systolic, and his heart rate is 122. Cap refill time is 3 seconds. He's a bit cool. Okay. So for a 20-year-old man to have those observations, are we worried? Are we not worried? What do we think? Pop it in the chat. And how worried? Yeah, good. Worried. I like that. We're very worried. Okay, so for a 20-year-old man to be in shock is seriously concerning, because young fit people compensate so well with their cardiovascular system. Okay, so at this point you need to be, if it wasn't before, this is now peri-arrest. Get everyone here that you need to be here. Okay, because this man he's got potential to go very unwell. Disability, nothing comes up, so nothing too concerning there. He's not febrile. And exposure, the only thing you note is that he's got bruising across the right side of his chest, okay, likely which will be from the trauma. All right. So then what do we do now? So we need, sorry, I'll go into that in a minute. We need people there. He needs, yes, peri-arrest, exactly. You'll get all this in your inductions, but peri-arrest in all hospitals is 222, like the major hemorrhage protocol, and you just specify, I would like a peri-arrest, and you say the floor that you're on, the department that you're on, and is it an adult or a child? Okay. BM is, oh God, what does it stand for? It's blood sugar. BM is I think is the name for the is the company that designed the kit to measure blood sugars, and I can't remember what it actually stands for, so sorry about that. So fine, okay, so the arrest team come, brilliant, they are able to put a chest drain in, fantastic, and he starts breathing again. However, so on a 15-litre mask, he becomes a lot more hypoxic. Okay, let's say he doesn't have a chest drain in at this point. What are you worried about now? Okay, so I'll give you a clue. His trachea was central before, but now he's become a lot more hypoxic and he's in a lot of pain. what do we think might have happened? Yes, very good. So we're thinking he might have a tension pneumothorax, okay, which is where the pneumothorax gets so large that it presses on the not only the mediastinum, but the trachea as well, okay, can cause airway compromise, as well as cardiovascular compromise, and that is an emergency, okay. And this is what his chest X-ray would likely look like, okay. So as you can see here, hopefully you can see my mouse, you can see the collapsed lung here. This is the border of it, all right. And now it looks all dark all around here, right? And this is just air between the pleural space, okay, that you can see. On this side, you can see there's nice lung fields that extend right out to the ribs, right out to the periphery, okay, but you do not have this on this side. And we know it is a tension pneumothorax because if you follow the trachea here, you can see it deviating off to the left-hand side, as well as big mediastinal shift. So you cannot see any of the mediastinum on the right-hand side of the vertebral column, okay? So that's a tension pneumothorax. Right, in the interest of time, we'll go into our second case. So case number 2, I haven't put any of the ATV on here because I want you guys to think about it for yourself. So you are bleeped by a nurse as a patient on one of the wards has become short of breath. Let's say it's 11 p.m. at night and you are covering the wards. What are you going to do? What do you need to do there and then when you're speaking to the nurse? Yeah, fantastic. Get their vital signs. Yeah, exactly. Ask for obs. Hopefully she'll have done them, particularly if they're short of breath, but often they haven't. Okay. Particularly if they're short of breath, you're worried about their respirates and their sats, and you need to think, yeah, and as well as their blood pressure and heart rate. Quite right. The other thing that I often do on the phone is, particularly with nurses that you know are very good, and all nurses are very good, but the very experienced ones who've seen a lot of pathology in their time, just ask them that, how does the patient look? Are you worried about this patient? If they say yes, then you need to go and see them straight away, okay? If their vital signs are significantly off, then again, you need to go there straight away and prioritize it, okay? And again, as before, it's A to E, A, B, C, D, E. So let me just get the second case up. Sorry, I've got it written down on a piece of paper. Okay. So it turns out to be a 70-year-old gentleman who has come into hospital. They were treated a few days before with a UTI, but there's a few social issues. So they haven't managed to get home yet. And now they've become short of breath. So their Airway is patent. Their SATs are 88% on 2 liters of oxygen that the nurse is currently stuck on them. They've got a respiratory rate of 26. So that's their respiratory vitals. They've also got a blood pressure of 101/77 and a heart rate of 121. So Airway's patent, breathing, having a think about what we're going to do. So again, listen to the chest. Can you hear any crackles? Look at them. Do they have an increased work of breathing? We've got their vital signs, and on auscultation in this scenario, you find out that he's got some crackles in the right lower base. Okay, and as I said, the SATs are 88% on 2 liters. So we're going to increase his oxygen, put him on a 15-liter non-rebreathed mask because this man is hypoxic despite oxygen therapy. We're also going to get a blood gas on him, and he'll probably need a chest X-ray as well. Okay, but with crackles on the chest, what are we thinking about? What diagnosis? Yeah, PE, HAP. So PE, yes, you can get crackles on the chest, and lots of patients will have incidental crackles on the chest if they've got underlying lung disease. But in this scenario, if they've got sort of unilateral consolidation, I think, or unilateral reduced breath sounds or crackles, then I think hospital-acquired pneumonia is the most likely. If they had bilateral crackles, you'd be more than, it'd be very reasonable to think about heart failure, so some pulmonary edema. But you're right, any patient in the hospital that is short of breath, PE is always something to remember and never something to forget about, okay? Because they happen very commonly, actually. I was amazed by how often you saw PEs in hospital, all right? But yeah, we're thinking about a HAP. Moving on to C, his blood pressure is 101 systolic and his heart rate is 120, okay? So are we worried about this chap? Are we not worried about this chap? Yeah, very good. So I would be worried because I think this man might be septic, okay? And yeah, medium worried. I like that. Yeah, so this is not an emergency. You don't need to put a peri arrest out for this right now, but he does need to be looked after there and then. Okay, so we're thinking about sepsis with the chest as cause. The chest is his cause for sepsis, likely a hospital-acquired pneumonia. So in this case, what do we do with septic patients? Anyone? Yeah, perfect. Sepsis 6. So we give 3 and we take 3. So giving 3 is giving him oxygen, which we've already done. Giving him IV fluids, so putting in a cannula and give him IV fluids, and giving him some antibiotics. All right, antibiotics, just check his allergies. Okay, that he could have anaphylaxis to penicillin. Okay, and you do not want him to give him Kermoxiclav. All right, so you give broad spectrum antibiotics, fluids, and oxygen. Good. And we take 3. So we're taking urinary output. So we need to monitor that closely. So then either you or a nurse needs to put a catheter in with strict fluid balance monitoring. You need to take his lactate just basically as a marker of how unwell they are. So septic people get very high lactates because the rate of anaerobic respiration that's occurring in their body from an infection is very high, particularly if they're hypoxic. Okay, so that just gives you an indicator of how concerned you are. And actually, when you come to hand over or to escalate this to a senior, the the lactate is something that they will ask you about because it is so useful in an acute setting. And the last thing you need to take is blood cultures. All right, so yes, they probably have chest as their cause of their sepsis, but you don't know that they might actually have a UTI, or they might have a wound sepsis, or they could have a meningococcal septicemia. All right, because you haven't got there yet. So it's really important to take blood cultures, which will take a couple of days to come back, but in the acute setting, very useful. All right. D. So going back to temperature, are they febrile? Okay, so is their temperature above 37.5? And if so, by how much? Have they got a raging fever of 39, 40? Okay, it's all markers of how concerned you should be. And if they're febrile, it's likely, it just adds evidence to the fact that they're septic. Okay. Again, do all the things with D, do a BM, do their GCS, and check their pupils as well, just as part of a systematic approach to make sure you don't miss anything. Okay. And then E, have a good look at them, look at their chest, have a feel of their tummy. Are there any wounds? Are there any lines? Just, again, be systematic. Okay. And depending on how unwell they are, how worried you are, escalate anywhere along that line. Okay. So you treat them with antibiotics, you give them a fluid bolus, their blood pressure comes back up, you give them another litre of fluid over the next sort of 4 hours. They respond to oxygen therapy, and they require you can titrate their oxygen down to 8 litres. You've sent off cultures, you've sent off bloods, you've given antibiotics, and all you've done there is stabilize the patient. Okay, and it's fantastic, and that's exactly what your what you want to become a doctor to do. Okay. Right. Last case. A nurse bleeps you again. 67-year-old man who, well, let's make it a woman this time. 67-year-old woman who's got a new oxygen requirement. Okay. She doesn't think they're short of breath, but their sats just dropped. She says, he had a hip replacement, total hip replacement as an elective patient yesterday. So first of all, as before, we're going to just say, can you get some vitals? Are you worried about the patient? What's his background? Okay, and depending on how bad the vitals are, determines how quickly you need to get there. Okay, so it transpires that he has oxygen saturations of where are we? I haven't written them down. So let's say he's got oxygen saturations of 90%. He's not on any oxygen. His respiratory rate is sort of 23, and but his blood pressure is stable, and he's not tachycardic, and he's afebrile. Okay. What are we thinking? What's our differentials? As you're walking to see the patient, it's always good to just think of differentials in your head. Yeah, pretty good. I think 3 have shouted for PE, which I'm a big fan of. As I said for the previous case, PEs are very, very common in an inpatient setting because patients just do not mobilize. All right, it's a huge risk factor for PE. Now, this chap has one of the biggest risk factors for pulmonary embolism, which is having had a orthopedic surgery. Okay. So he's had a hip replacement the day before. Okay, so like anything, we're going to go A, B, C, D, E. We're thinking maybe he's got a PE, but common being common, we're not going to rule out a chest infection. Has there been any trauma on the ward? Has he fallen? Could he have a pneumothorax, a hemothorax? Is he overloaded? Is there a pleural effusion on one side? Okay, so all things just good to have differentials in your mind as to why he might be hypoxic. So you get their airways patent, he's talking to you. His breathing, as I said, is SATs at 90% on Romaire, and he does seem to have a bit of increased work of breathing. He's slightly tachypneic, but he's not using his accessory muscles. He just seems a bit out of puff. Okay. So that's looking at him, he doesn't look cyanotic. And then we're going to auscultate his chest. Actually, pretty good air entry. A bit reduced at the bases, but can't hear any crackles. Percussion is normal. Okay. Again, in this situation, an ABG can probably wait. You can carry on, finish your A to E assessment, and then do an ABG later, and think about a chest X-ray later as well. Moving on to C, as I said, he is stable, his blood pressure is fine, and he's not tachycardic. Cap refill time sort of 2. He's warm and well perfused, and there's no obvious signs of bleeding. And heart sounds 1 or 2 present as well. So again, you don't think that he needs some fluids right now. We've just actually, I think oxygen is all he needs at the moment. Okay. And then D, you run through it. His GCS is 15 out of 15. He's afebrile, pupils are normal. Yeah, so, and his BM is 7, so we're not concerned about that. And then E, so E particularly he's had surgery, so we want to look at the wound, and we want to see if he's got any lines in. Okay. And also have a feel of his abdomen. It's always good to be systematic, as I said. Wound looks healthy. It's not discharging anything. It looks to be healing okay. It's obviously only day 1 post-op, but nothing majorly concerning. As he's had a hip replacement, always good to just do neurovascular status on that limb, particularly checking his distal pulses on his leg, and check the cap refill in the toes, and just very briefly check sensation and motor function. So we're thinking PE is the most likely option here. So what are we going to do for this gentleman? What does he need at this point? Yeah, very good. So as I said, ABG will do now because it's important to see just how hypoxic he is. And that's useful to discuss with a senior when you eventually do discuss it. What do you think, if we're thinking about PE in an orthopedic patient, what might it be good to check? Yep, well score, fantastic. That's really good. And actually, when you end up requesting the CTPA, you'll discuss it with the radiologist, and quite often they want their well score, and it will be very high in this patient because he's immobile and he's had orthopedic surgery. Yeah, D-dimer, very good. More useful if you're unsure. Okay, so if a patient's, the hospitals typically have it, if their well score is less than 4, then do a D-dimer, and if that's raised, do a CTPA. If not, just go straight for a CTPA. And the reason is because D-dimers are very non-specific. So any infection can cause a raised D-dimer. Other pathologies also can. It's not just clots. All right. Just going back to exposure, what is it important to examine for a chap that we think might have a PE? Calves, very good. Yeah. So we're looking at the calves to see if they're soft, non-tender. If they're not, if they're hot, if they're larger than they should be, if they're particularly red, they're really tender, we're worried about a DVT. Okay, and that just adds to the clinical suspicion for a PE. Okay. Yeah, what should we check for a man that has, I'm thinking about now, you've done your A to E. We're going to look a bit more about his background and check everything else. What can we look for? What's it important to check to see that might have increased his chances of having a PE? Very good. Yeah. So not so much INR, but is he on VTE prophylaxis? Okay. So every surgical patient really should be on VTE prophylaxis unless they're at high risk of bleeding. Orthopedic patients should all be on it pretty much. Okay. So typically they're put on prophylactic doses. For the normal person, that's 5,000 units once in the evening. And you look at the drug chart and you see, oh, he had a surgery at 11 a.m. yesterday, but he missed his deltaparin dose last night. Okay. So he hasn't had any VTE prophylaxis. And again, it's all just backing up your cause for your thought processing as to why you think he might have a PE. Yeah. So then again, at this point, discuss it with a senior, because he is stable. He's just on oxygen. All right. If he was unstable, discuss it earlier. Communicate effectively with the nurses as to what we're going to do. And we need to organize a CTPA as quickly as possible. And depending on what your senior says, you can actually give him a treatment dose, deltaparin there and then, or they might say wait to see what the CTPA comes back for. All right, so that is just a bit. So that's just a very standard PE example, and you'd be amazed about how often you actually see it in hospital. So that is me done. Any other questions? Sorry, I can see one on Q&A. How does the C, A, B, C, D, E assessment differ? That's a very good question. So C, as I understand it, stands for catastrophic hemorrhage, which is basically useful in a patient who's had severe trauma that might have been helicoptered into A&E, but obviously might not have been if they've been hit by a car. And the C it's catastrophic hemorrhage, so you can see it most often. It'll often be an open fracture of their femur. It could be a large intra-abdominal hemorrhage, in which case you think about doing an ultrasound, a fast scan. But it's put before the A because if it is genuinely a catastrophic hemorrhage that you can see, then that will kill them quicker than a blocked airway. Okay, but it's pretty obvious when you see it, and it's only really relevant for trauma patients. Okay, so don't worry too much about it on the wards, is what I would say about that. All right. fine. So there is a feedback form there for you guys. If you don't mind just filling that in, it's a very quick feedback form. And again, I will stay on the line for another 5 minutes or so to just answer any questions that anyone might have. Hope that was useful. I'll just check that there's no. Yeah, good question. Can you do a VBG instead of an ABG? Always something that people are unsure about, particularly when they're starting F1. So the difference between an ABG and a VBG is obviously it's an arterial gas rather than a venous gas. So the blood has come straight from the lungs, okay? So it gives you a really good reading about their genuine oxygen level and their genuine CO2 level, okay? Now, if the patient's not hypoxic and their breathing is okay, then a VBG is normally satisfactory, because you typically only look at it to see what their bicarb is and also their lactate, and to check if they're acidotic or not. And if you can't get an ABG, a VBG is always useful. But if a patient has respiratory compromise, then an ABG is pretty much essential. And if you can't get one, that is completely okay. Escalate it to a senior, to someone more experienced who will help you get one. Okay. Yeah. Do I know what I want to specialize in? Yeah, I'm quite lucky in the sense that early on at uni, I knew I wanted to do surgery, because I just found the pathology more interesting than medicine. And I like the hands-on stuff. I like going to theatre and doing things and fixing things. In terms of what specialty within surgery, I've just done a general surgical rotation and I absolutely loved it. So that's my plan for the moment, but do not worry at all. Okay, there's F2s that I know, there's F4s, there's F5s that still don't know what they want to do, and that is completely okay. All right. But just try and get as much exposure as you can.